Hello and welcome to today's HIPAA Chat Q&A lightning round. I'm Carol Fly with High Tech Answers, and on the line, of course, is our host Steve Spearman with HIPAA Chat.
Yay! Lightning round!
Lightning
Yay!
round.
Lightning round, by the way, that means all HIPAA-related questions are acceptable.
That's right. We're going to try to answer 60 questions in 60 minutes or die trying.
Yes, yes. Can we do it? That's the question. Like, is this within our superhero capability set? So,
I don't think so. I'm pretty confident that George Clooney and Sandra Bullock could do this, but I don't know about you and me.
Well, they're doppelgangers. Doppelgangers are never the same. I actually just saw an article about doppelgangers.
Yeah.
It's like, apparently it's a thing.
Yeah, no, I need like 5 of them.
Yeah.
HIPAA Chat is, of course, sponsored by eFax Corporate, a brand of J2 Global Cloud Services. We could not have HIPAA Chat without eFax Corporate, so please visit them online at enterprise.efax.com.
Yay, eFax.
And then, of course, about Steve Spearman.
George Clooney.
Steve, aka George Clooney. Steve has been in the health IT security space for a long time, as you can see, since 1991. And
well, not really. I've been in IT, healthcare IT since '91. Security, not quite that long.
Not quite that long.
Maybe a few years. Yeah.
Just looking at your young visage, it's hard to believe.
I'm a quick start, though. I'm a quick start. I learn stuff. I master stuff, really.
Besides working with some of the RECs and clients throughout the space, both hospitals and physicians, Steve also hosts his own series of monthly webinars you can check out at that link, healthsecuritysolutions.eventbrite.com. And, of course, email him at spearman@healthsecuritysolutions.com, and he will answer your questions.
I will.
So I'm going to leave... I'm going to just lead right in here, Steve, because we are going to try to get through 60 questions in 60 minutes, and we don't know if that's possible, but we're going to find out.
We're going to give it our darndest.
Yes, so I'm going to jump right in. And these questions are completely random because they're
Yes.
really just by order submitted by the audience. So
Okay.
no rhyme or reason. All right, number 1. All of HIPAA is important. However, if a single physician practice is doing their own SRA report, their own security risk analysis, what do they need to do to pass an audit? What's vital?
By the way, I've got a stopwatch.
Okay, me too.
Yeah, so it's
Call
like
my iPhone.
Yes, I've got one on my iPad. It has bigger letters, and so yes. So hit start. There we go. So as I've said before in other podcasts, meaningful use risk analysis is the same thing as a HIPAA risk analysis, even though I think we might end up talking about a little bit of the future that changes that a little bit, but it needs to be dated within the reporting period. And I actually have had some clients that have had the issue come up of oops, I'm sorry about that. Let's see here. I've had where they got a risk analysis from me, but they're now being audited for prepayment audits, and I didn't do it for the reporting period, so I'm having to help them try to think through what to do. So it needs to be done within the reporting period, and it can't be a checklist. I mean,
Right.
Go back, if you go and look at the Guidance to Security and Privacy of Health Information Technology from the ONC, a document that's been recently updated, by the way, and they don't have this page anymore, but on myths and facts, I mean, that gives you some good guidelines. It's not being done by your EHR. The use of your system doesn't constitute it. You really should have an inventory. A checklist does not suffice. I mean, all those sorts of things. So, do a good job and make sure it's done within the reporting period and dated within the reporting period.
Exactly. Are there any HIPAA security rules related to the use of free EHRs?
So there are not rules that where it says, hey, because you used a free system, you don't have to do stuff. There's nothing like that. There is the reality is that you have to comply with the rules, whether it's a free system. And I don't know if this is really what they were asking, but if it's a free system like Fusion, is it Fusion or
Practice Fusion?
Practice Fusion, that's right, is one that you find a lot. They have to comply with. Its use has to comply with the regulations and with meaningful use, just like any other system does. There are, I suspect that from a meaningful use compliance standpoint, there might be some issues that are kind of that might pop up specifically to issues around support, where if you're using free system, you might have
Right, not much
issues
support with
that,
your vendor.
maybe you're not going to get the support, but I mean, there's nothing that forbids it in the rule, and there are no special exemptions because of it.
It's kind of a big question here. Can you address requirements on data encryption?
Yes, and we talked about encryption a lot, and it comes up a lot. And I'm trying to remember. Did we have a program that talked about encryption specifically?
We did. We had the one on. We had one on that a couple months ago, and then of course we talked with Mike Pearson in March about cyber hacking. And by the way, for our audience, you can find past HIPAA chats, and specifically that one on cybersecurity, where we talked a lot about encryption, on our High Tech Answers YouTube channel. If you go to YouTube and search High Tech Answers, you'll find the channel pretty darn quick.
I bet you if you went into Google and put
you probably could.
High Tech Answers YouTube, it'll probably go right there.
It'll pop up.
I bet you even if you use Yahoo as your search engine, it might find it. Probably on the third page though, but it will be there.
Slam against Yahoo.
Yeah, because Google owns YouTube. So what was the question again?
Can you address requirements on data encryption?
Sorry. So, okay, encryption is an addressable safeguard. In the two places it's mentioned in the rules, it's addressable. Hopefully we'll have a chance to go into addressable a little bit more later, because I hope somebody has asked about it. But so that means that you have to encrypt where it's reasonable and appropriate to do so, and you generally think about encryption of data at rest, data that's stored somewhere and when it's being transmitted, and so when you have to encrypt is really tied to determining through procedures such as risk analysis and evaluation whether it's reasonable and appropriate. So you have to encrypt when it's reasonable and appropriate to do so, and there are different factors that go into that. Hopefully we're going to talk about that a little more, but later.
Yeah.
So but it's a very general answer to a very generalized question that's super important.
Do you have any insights to auditing frequency of those who have received EHR incentive funds? And this is a question that came up on a webinar we did with Jim Tate, our RMU expert.
Yes. Jim is the guru of meaningful use generally, and certainly audits particularly. In fact, he should go and get. Did you know .guru? You can actually get .guru sites. His would be meaningful use. .guru. I don't know if that's taken, but and so the thing is, at the end of the day,
it is now.
Yeah.
You just brought it up.
Right. Well, go check it out. Like there's also .ninja, I think. But anyway, so go check it out. But the answer is that we don't know exactly. What I know, and some of you may know, that I actually filed a Freedom of Information Act request last February that resulted in an article in infographic in the last quarter of last year around of how many people have been audited. About 10,000 eligible providers have been audited. About half of those are post-payment audits, and about half are prepayment audits. We don't know in terms of the percentage that have been audited, but and I don't know what y'all are finding, Carol, and what you're hearing too, but I am getting an awful lot of requests from people, or getting email from people that are going through prepayment audits.
Yes, prepayments are increasing, and also just news broke within the last 2 weeks that OIG, the Office of Inspector General, is also going to start conducting. So audits. The point is, no matter what the percent is, it's increasing. Prepayment audits are increasing, and audits in general, with OIG doing their own set of
Yes,
of
I mean, you should expect to be audited. At the end of the day,
yeah, you should
prepare for either an OCR audit, a meaningful use audit, and now an OIG audit. And right. Carol, I don't know if you've seen the particulars, but those OIG audits seem kind of scary because they can cover. I understand they can cover multiple meaningful use periods. They could say,
they do,
because it's like so. Whereas like the
Yeah.
Figliozzi are going to say, okay, we're going to audit you for this reporting period.
And of course,
And
for
if it,
some providers, that could be 4 years right now, 11, 12,
yeah,
13, 14.
absolutely, yeah.
Yeah,
And
yeah, no, it's very, Jim Tate's doing a post next week about it, but it's
yes.
very, very particular. Yeah. Hmm.
Yeah, yeah. So anyway, so we're keeping an eye on that, but it's hard to know numbers. We know though from the FOIA request that I made last year that about 25% of physicians fail their post-payment audit, and about 22% fail their prepayment audit. And I wonder if that number, given the numbers, I wonder if that number is actually higher now than it was.
Oh, yeah, could be. Yeah.
Because I mean, we don't know, but as of last August, that means 1 in 5 are failing their audit. I
Yeah.
don't think that's a good number. I would definitely, make sure you got your stuff
Your ducks in a
together.
row. Yeah.
Yeah.
For HIPAA breaches that are reported, do you also notify state agencies where the provider holds their license?
This is like stump the expert.
Stump the host. Stump HIPAA Chat.
Stump the host. Yeah. Am I going to lose like credibility points?
No.
Okay. Um, I honestly don't know the answer to this question. Okay, read the question to me again.
For HIPAA breaches that are reported, do you also notify state agencies where the individual holds a license? And I
To
guess
my knowledge, okay. So the answer is okay. First of all, when you say breaches that are reported, so I want to just say all breaches have to be reported,
right.
either annually or if it's over 500 records, they have to be reported within 60 days. And I do not believe there's a requirement to report that beyond the federal reporting requirement. I may be wrong about that. But you do, and that actually may be governed by state law. So I'm not really sure, but I'm pretty sure there's not a federal requirement that you have to report it to the state in which you're licensed. I can't imagine why there would be.
Okay.
So
It's a great question. How can we avoid redundancy when doing the security for HIPAA and the security requirements for compliance with meaningful use?
Yes.
You get this question a lot. I know you do.
Yes, I do. So, and the answer is that you can avoid it because they're really the same thing. Meaningful use, so in its the wording, it unambiguously states that you have to conduct or review security risk analysis per 45 CFR 164.308A1 and implement security updates as necessary. That's stage 1. Stage 2 has some additional language. It has the same reference, though, and that reference is to the HIPAA security rules. So to me, the only proper and certainly the most natural reading of the rule is that meaningful use requires you to do a HIPAA risk analysis. So the second thing, what we've had that supported that contention is the fact that the ONC itself has published guidelines. This was been actually published about 3 years ago, but published guidelines on this in which they explicitly state that you have to conduct a risk analysis and that it needs to include all the assets associated that are processing protected health information, and it uses copy machines as an example of that. However, I want to say, if we have a chance, I think if there's a question about meaningful use stage 3, that 3 is going to kind of throw a wrench into this. Okay, yeah, we'll get into that a little bit later because that may be different going forward. But as of stage 1 and 2, they're the same thing. So it's not redundant. You do a HIPAA risk analysis, and that's what you do to comply with meaningful use.
Okay. Sort of leading into that from our audience, when does the SRA need to be completed for MU attestation, and what items need to be addressed and remediated before attesting? It's a great question.
Okay,
Happened quite a while ago, but last year.
When does it need to be done or dated, right? That's the first question. Okay, and then what needs to be remediated? Okay, so it used to be, and this is something that Jim Tate and I have commented both on in our various public forums, but So it used to be that the rules were pretty unambiguously clear that what you had to do was that you needed to conduct and document your risk analysis prior or during the reporting period. I sometimes say prior to, but that does, which is possible during a 90-day reporting period or a quarter reporting period, because that's sort of allowed during a year. It has to be done during the year, and that was kind of the clear rules that you have to do it during the reporting period or prior to the end of the reporting period is the way the language expresses it. And that's been my advice. It's still my advice for a reason I'll get into, even though last fall, CMS in an FAQ documented that, and even there was a little bit of some drama, soap opera-esque drama around this FAQ, because they said one thing and then about 2 weeks later they changed it and corrected it. And with that correction, they made a clarification that would presumably allow for a reporting period, as long as it's, would allow the risk analysis to be done after the reporting period as long as it's done prior to the attestation. So if you had a Q4 reporting period in 2014 and you attested on, let's say, February 28th, and you did your risk analysis on January 18th and you documented it as January 18th, then under that FAQ you would be okay. You'd be I personally recommend everybody to do it during the risk analysis reporting period, because I think that's a clear reading of the rules. But you do have something, if you do it afterwards, as long as it's prior to testing, you've got something that you can kind of back your claims up with,
right,
so to speak.
Right.
So a lot of confusion around that. Now, and the second part was read that second part again.
Yeah, the second part. Let me find the question again. Hold on.
It was. Oh, sorry, I threw you off there.
You did. I was wondering. What items need to be addressed and remediated before testing?
Yeah, so because it does say and implement security updates as necessary. So it's not clear. So I say, listen, you really need to address critical findings of your risk analysis. That's sort of the simple thing. It's like, and for some organizations, there may just be one, there might be none, but you want to, I'd say the best way, if your risk analysis says you don't have anything that's critical, then document that in the security management plan, and I think you're good to go, so I think a good rule of thumb is policy-related issues should be addressed and critical findings should be addressed.
Okay. Sort of another question on SRA. What your favorite question? They want your opinion here. What do you think of the SRA tool created by CMS for small practices?
Oh, the SRA. So, Carol, yeah, this is read my mind time.
You would not give it a gold star.
I would not give it a gold star. Yeah. Yes, I am not a fan of that tool for reasons that I kind of go into on my website. I have an article that's called "Assessing the Assessment" or something like that, and it's specifically about that tool. I think it's a terrible tool and is very difficult, exceedingly difficult in a manner where you can actually fulfill the obligations of HIPAA to understand the threats and vulnerabilities to protected health information. However, having said that, I think it would be extraordinarily tacky for like Figliozzi or CMS to have somebody fail an audit because of an inadequate SRA where they used that
their own tool.
Where they used it in good faith. Now it's quite possible and quite easy to not use it in good faith because you either don't know what you're doing or you're not thorough enough or whatever. But if somebody were to use that tool in good faith and use it, as designed, it would be extraordinarily tacky for them to fail a risk analysis. So not a fan, don't like the tool. I hope you don't use it. And in fact, if you have to go and, if you're determined to use a risk analysis tool, I do strongly prefer the HIMSS. You can easily Google this, HIMSS Risk Assessment, and HIMSS is HIMSS.
And
You
you
and
will
I were
find
just
it.
at the
You
yeah,
want the HIMSS
risk
stuff.
analysis. And you could also Google National Learning Consortium risk assessment tool. That was a tool that was developed and was distributed by a lot of the regional extension centers. And it's better, in my opinion, than the SRA tool. So anyway, that's kind of my take. I don't like the I don't like the CMS tool at all.
And just a quick plug for Steve. You actually have your own SRA light in a box for small providers. So
I do. It
yeah,
works. Yes, I really, and I got to say, I mean, we do very, very good work. It's a remote facilitated risk analysis, and my clients are very, very happy with the results, because it's not just like this thing that allows them to say it to a test, but we actually do a lot to get them well on their way to being compliant with HIPAA, because it includes policies and procedures, it includes a security management plan, and we just really bend over backwards to, to help them, really,
yeah.
really deal with the HIPAA stuff.
So email Steve.
Yes,
Yeah,
tell me.
yeah. Email him. Yeah, exactly. How, just some general preparation, how, guidance or advice, how should covered entities prepare for a HIPAA audit? I'm assuming they mean an audit by OCR.
Yeah. So yeah. So this has a lot of ramifications, and with stage 3, even we'll sort of talk a little bit about it. But let me start the answer to this question by, you prepare by being compliant. That's the real answer. There's a way you can answer this question where it's like, okay, here are the tasks. Now I'm being audited. Now here's the tasks of the things that I want to make sure I assemble to send to them. But the thing is, really, you can't assemble something if you've not been compliant in an ongoing sort of fashion. So here is my definition of compliance. Compliance, as it refers to HIPAA, and is really kind of true about all of these. Compliance is having policies and procedures in place that are mapped to the regulations, that reflect the findings of your risk analysis, that are followed, and that you can document you follow through logs, reports, forms, checklists, etc. And the way you would get ready for an audit is by assembling the policies and have that regulatory map and the document supporting that you're actually following your policies. That's kind of the simple answer.
Right.
Answer to it. So yeah. This is actually a good point. We're going to be adding a new deliverable to our service, our risk assessment service, that is going to provide a way to document those various forms and checklists and things like that. And so yeah, stay tuned for that. That'll be something we're busily working on, and we'll hopefully get out soon.
There you go. Sort of another big picture question, which hopefully has a simple answer. Who must comply with the HIPAA privacy and security rules?
This is a good question. So the answer is covered entities.
Yeah.
Who are organizations, entities, individuals that provide that treat patients and bill insurance companies. So they that would be your everyone from your podiatrist to your local hospital. They're covered entities, and then business associates. And business associates are contractors that, under the terms of their contract, are required to comply with under the terms of contract they require access to protected health information.
Right.
And so that's the simple answer, is covered entities and business associates.
So
I will say too, I think that there is confusion about who's a business associate a lot of times.
Yeah, and in fact, that was my next question on the list, which is, what is the definition of a business associate?
So a business associate is, as I said, a contractor that requires access to protected health information in order to fulfill the terms of the contract.
Not the janitor.
Not the janitor. Your housekeeper. So there's actually, an example. Your housekeeper is not. Now that doesn't mean you should still have a contract that says, hey, there's confidential information here. You need to make sure you don't mess with it. But they don't need PHI in order to clean your office.
Yeah, right.
There's actually categories that people don't think about often enough, like your shredding company is a business associate. Your answering service.
Sure.
This one's yeah, because we're thinking about it. They're taking messages from your patients.
From your patients,
and that patient's saying, hey, I've got a really bad earache and I'm on this medication, blah, blah, blah. That's PHI. And so they're, having to do it. Shredding companies, transcription companies, that one tends to be a little bit more obvious. Those are three that, we ask about when we are doing our risk assessment, among others. But the real thing is understanding that, they're processing, managing, storing, viewing protected health information in order to do the work that you've assigned to them.
Which is a different thing than having your janitor break into your server room and steal your server or your computers.
Yes, and that would be something he could go to jail for. But that doesn't change the fact that under the rules he's not a business associate. So you would want him to have signed an agreement that says he's gonna protect your PHI. I know there's a confidentiality agreement, not a BAA, but even without that, he's violating the law. So
right.
There are remedies there for sure.
Does the security rules define what is meant by an incident, and if so, what is an incident?
This is something I've had to research recently. Interestingly, yes, and I think. It does, but the answer is yes. It does define an incident, and so an incident under the rules is an attempt or successful unauthorized access, use, disclosure, modification, or destruction of information or interference with system operations in an information system. So that doesn't mean that's a breach. So there's a very distinct difference here. And so an incident really literally is something that either did or potentially could have compromised information in some way. And an incident can be like, it could be defined your policies, and you actually need a policy to define that. But you might define a policy that says, okay, if my firewall indicates that I have a certain port that's being pinged, 100 times, a bunch of times a minute or whatever, then that might be an incident, and you would need to then document that, and but you do need to define it in your rules, and beyond the general description I just had, there's some latitude about how you can describe that. I actually think it's important that organizations get this right, and especially in business associates get it right. And one reason I think it's important is that the business associates agreement does require you to disclose to the covered entity of the incidences that happen. So how you define that incident is important from both a contractual and a regulatory standpoint. The thing is, though, per what I just said earlier, an incident's not the same as a breach. And I've actually had a client say, well, it was a non-reportable breach, and you've heard me say this.
That's an oxymoron.
It's exactly right. I say, no, you had an incident. If it's a breach, you have to report it. And then there's the language is actually even more explicit about what a breach is.
Is faxing using cloud solutions HIPAA compliant? I keep getting conflicting opinions regarding faxing and HIPAA. Go visit enterprise.efax.com.
Yeah, you mean you're not using eFax? I mean, what's up with that? eFax yes, it's allowed, and eFax is actually extraordinarily conscientious about its obligations under the HIPAA rules, and so yes, it is allowed. I'm a big fan of those solutions, and if you go with a solution like eFax, they have capabilities like, for example, logging and auditing that are either difficult to get out of your own system or maybe in some cases impossible. So yes, that's definitely allowed. Just remember that you know, that those providers, such as eFax, are business associates.
Right,
So
absolutely.
if they won't sign a business associates agreement, it's time to go to eFax, who will definitely sign a business associates agreement.
Right.
And so, yeah. Interestingly, this is more like trivia, but traditional fax machines are not actually covered under the security rules. They're considered analog, sort of like, you know, talking and stuff. But, you know, most people are moving and have already moved to like
Absolutely. To e-faxing. Yeah. Yep.
To e-faxing, of course.
E-faxing with eFax. Yep. Mm-hmm.
Yeah.
Are you ready for stage 3?
Am I ready for stage 3?
I know.
Yes. I mean, you know, we're you know, it's going to be a modified stage 2 for at least a couple more years. So
yeah. For those of you who aren't aware, stage
the rulemaking.
Yeah, proposed rules for stage 3 were released ahead of HIMSS, and it's expected that they'll be finalized probably midsummer.
Yeah, no later than August 1st, and they said they're feeling a sense of urgency to get it done as quickly as they can.
They are.
And yeah, they have. I think one of the most interesting. We can now confirm. I mean, it's not the rules, and I'm sure you were in there too when they were talking about this. But it's almost certainly going to be a 90-day reporting period again in 2015, mm-hmm. and you could report during any contiguous 90-day period in 2015. So once that becomes the law, if your numbers in your system look right for modified meaningful use stage 2 from, let's say, January 1st, you can actually attest immediately.
Right.
Which is a reason you need to go ahead and do your risk analysis now,
Absolutely.
so you can get your money soon. Right? So, I mean, I know that's shameless self-promotion, but I'm just looking out for you. I just promise.
Well, speaking of stage 3, in the proposed rules anyway, were there any big changes regarding security risk analysis, SRA?
Yeah, that's so. And it's interesting. I've downloaded it. It's actually called Objective 1, which surprises me. And I don't know if that means it's going to actually be the first criteria. And you know, and I think a lot of the listeners may have heard that they're actually making, you know, they're reducing the number of, you know, criteria, et cetera. But regardless, yeah, they are making a change that I kind of think is interesting. That is a change from what I said earlier. So in the past, as I said, I tell people doing a HIPAA risk analysis and meaningful use risk analysis, they're the same thing. In stage 3, the proposed rulemaking, which I'm assuming will be close to that, it basically both adds some HIPAA compliant stuff, but takes away some as well. In other words,
it giveth, but then it taketh. Yes.
It giveth and takes. So the way that it giveth is it narrows the scope of what's required for meaningful use purposes in conducting the risk analysis. So as I've said, the rules in the past, as well as ONC, you know, guidelines in the past, have said, you know, it has to include, you know, it's a HIPAA risk analysis, so it has to. You know, you have to, you know, identify the risks and vulnerabilities wherever ePHI is in your organization. And so that might be a copy machine, that might be, you know, any of a number of places that are not in your EHR. Stage 3, it narrows that. It says you have to make sure that you're, you know, that you do it. You have to make sure that you're, you know, doing a risk analysis for ePHI in your certified electronic health record. So I consider that to be kind of a narrowing of it. I'm not sure its impact is that great, given that for most organizations, most of their data is in the electronic health record anyway. Mm-hmm. So that's the interesting. It's sort of narrowing the scope in that sense. But then they add some language requiring that you have, quote, administrative, physical, and technical safeguards in place, unquote. And that is a pretty clearly playing fealty to HIPAA, because that's what HIPAA requires. So I personally think that I'm not sure that I think this is a great idea. I'm not sure it really saves that much, and I think it adds some confusion. But that is a change that's going to be interesting to watch. I will tell you, as for me, I will make no change. I'm going to do a HIPAA risk analysis, and I think that's what I think everyone needs to be doing. It's, why not? You just go a little bit extra in scope, and then you're HIPAA compliant. So, but in the rulemaking, they're actually pretty explicit. They're saying this no longer, this is narrower than HIPAA requires. And
yeah. As a complete aside, too, they at the briefing, they also said this would be the last stage.
Yes. Stage 3 is going to be there because that was always up for debate, even though we've been saying stage 3 for a while. But yes, they're going to.
They could obviously revise stage 3, but they're saying there won't be. Yeah. So yeah.
Hey, well, listen. Well, I'm curious. Then this is an aside. Well, this is our mid podcast of
2/3 podcast break.
HIMSS, yes. Was there anything else that you thought was really interesting that came out of HIMSS?
Yeah. I mean, this was the first year they did their cybersecurity pavilion, and
Did you walk through it?
I did. It was. I did, and so obviously, this is gonna lead into my next question too. It was obviously a huge topic at HIMSS this year.
Yes.
For them to devote that much attention and educational sessions to the topic. Pop Health and MU, of course, and interoperability, all the usual players, but cybersecurity was bigger than ever.
Huge.
Mm-hmm. Huge. Mm-hmm.
Yeah, we're entering a new era because of the Anthem and Primera and other breaches. It's like historically breaches have been focused on like loss and theft of client devices, usually laptops, but it might be other things. It might be USB drives. And we're entering an area where hacking is becoming the loss du jour, so to speak. The breach du jour that and it's changing the landscape a lot.
It is. It was right. Perfect. Didn't mean to segue the conversation this way, but our next question: hacking events are quickly becoming the biggest news items related to breach of PHI. How do you think this is changing the HIPAA compliance landscape, and what should organizations do to prevent being hacked? Well, first of all, they need to go to YouTube and check out the March HIPAA Chat on cybersecurity.
Yes, the EFACS high-tech answers. HIPAA Chat, where my technical consultant, Mike Pearson, was one of the presenters, and we talked about that. So I'm in June, I'm going to be speaking at the North Carolina HIMSS show, and the topic is connecting the dots. Connecting the dots. HIPAA and hybrid, cybersecurity. What's sort of the connection? And basically, there's some stuff that was true before that's just more true now, which is you need to do a risk analysis. You need to understand those risks. And I think on a practical level, that this means that things that aren't technically in the rules, like you don't technically have to do a vulnerability scan and you don't technically have to do penetration testing, you need to be doing those things. They're going to be needed. They need to be done because they're really required in the sense of, if you don't do those, you can't really identify the risks to the confidentiality, integrity, and So we're entering an area where technical security is going to become a bigger issue, and physical security is not going away. So loss and theft of devices. It's not like going to diminish. It's just going to become more overshadowed by having risk analysis that includes deeper technical assessments. And that's the way I'm thinking about it.
This becomes it's beyond HIPAA compliance. It becomes about your reputation.
Yeah, some organizations they'll never recover from the concept, or it'll be exceedingly expensive to recover from this. Now Anthem is huge, and they're a multi-billion-dollar organization, and they'll be okay. They've done some things that since the breach that a lot of people are kind of like scratching their head about, but no, you really and this is the thing is that. If there's in security terms, I think Mike talked about this, there's what's called a persistent targeted attack. And it's very difficult to defend against those. And so you need to do your homework and do what you can to prevent it. But you want to do enough that if you do have something like that happen, you can show an auditor that, listen, this is what we did. We did this and that. And, you want to minimize your liability risk.
Right.
So being thorough is going to be important, even more important than in the past.
Right. This is a great question. We do not have a corporate email set up in our organization. However, we have staff that use personal email occasionally to send documents that may contain EPHI. Is this allowed, and is it allowed if the document itself is encrypted?
Yeah, that is a good question. So I'm going to answer the first question, which is it allowed, and then the second question about if the document's encrypted. So the first answer is I'm just going to say no, and then I'm going to sort of, dial back a little bit. But really, you should not be using personal email to send EPHI. You just shouldn't be doing it. And the main reason actually is because of the business associate requirement. If you use Yahoo or your personal Gmail account to send protected health information, those organizations, because they're processing protected health information, they're business associates. But like in the case of Yahoo, to my knowledge, well, first of all, none of them, Microsoft, Yahoo, Google, none of them will sign a business associates agreement for personal services. So if you want, Google will sign one, and I've actually got a business associates agreement in place with Google, but I have an enterprise Google account.
Right.
So you have to have. It's actually pretty easy for most of these organizations to do this, but that means you have to be using an enterprise account associated with an enterprise, and so it's just not allowed to use personal email under those conditions.
Well, in corporate emails, I mean, it's so cheap to set this up. You know, I mean, this is like a no-brainer,
yeah, oh, absolutely,
right?
Absolutely, yeah. If you need an alternative, eFax.
Right, exactly.
Can provide all kinds of ways to do it. But you're not allowed to use personal email. And so the question is that, well, what if the data is encrypted? What if you're sending a file but you encrypt it? In my opinion, it still doesn't matter. They're processing, even though the data is encrypted, they maybe technically can't get at it. There, as far as I'm concerned, still would have to act as a business associate, something they're not willing to do. So let's just nip it in the bud, people. Don't use personal email for work. And some people will say, well, we use it, but we just don't ever send PHI. And I think that might be plausible. I mean, you might conduct business using a personal type of email account. I just think it's dangerous.
Yeah,
because then somebody, because they're so used to conducting business on that personal Yahoo account that they just forget, and I just don't think it's good practice.
Right. We have implemented a patient portal provided by our EHR vendor. Of course, patient portals are, you tough to buy an EHR system that doesn't have a patient portal these days. Are there any particular HIPAA security issues that I need to address related to this?
So yes, there are. First of all, in most cases, just remember those vendors, those patient portal vendors, they are business associates, and usually it's your EHR. Usually that's already not an issue, but there are third-party vendors, and they're handling that. And in a sense, by signing the business associates agreement, in many ways, it's a way that you are offloading some risk, because that's what you do with the business associates agreement, right? You say, you're going to handle some PHI for me, and in return, you're contractually and from a regulatory standpoint agreeing that you're going to put administrative, physical, and technical safeguards in place to govern the safety of that information. And that's what a business associates agreement achieves, is that kind of offloading, allows you to offload some of the responsibility and the risk. I don't think it's not everything. There are elements related to the deployment of patient portals that I think need to be better both understood and managed by the eligible provider or the eligible hospital. And so the main area where I explicitly check this with my work is related to what's called identity verification. And so with that, what we're getting at is like, you don't want to grant access to John Smith III,
right.
To John Smith III's chart to John N. Smith II or Jr. Just because you get the names mixed up or whatever. And so identity verification, I think, is an area where it's only a matter of time before we see a breach occur. And it could potentially, I think its impact will be limited if it's just that, where it's one person getting access to another. That's not the end of the world, but I think you're going to see a pattern of that happening. So you need to get identity verification right. If somebody calls you and say, hey, I'm John Smith, can you please send me access to my chart? My email is johnsmith@gmail.com. And that seems like it's obvious, but you'd be surprised. I mean, usually there's some piece of information like a birth date that they might have to confirm. But the problem is that a lot of times that data that's used for that confirmation is fairly readily available public kind of information.
Right.
So I'd like to see more boning up on that piece of patient portal access.
Okay. How long does the HIPAA privacy rule require covered entities to keep patients' medical records?
Did you know this is a trick question?
It is a trick question. Is it determined by the state?
It's a trick. It is determined by the state. It is not in the rules. The HIPAA regulations does not.
Carol.
The HIPAA regulations. Yay, Carol. The HIPAA regulations don't actually say, how long you have to. This is called document retention. It varies from every state. Some states are stricter than others. Some states, your pediatric charts have to be kept forever, and other charts for like 7 years or 10 years. The only area that's document retention related in the regulations, I say the only, but the only obvious ones that are come to mind right this second, is that you have to keep your documentation related to compliance for 6 years.
Oh,
so you have to keep policies, all those. You remember when I said checklist forms, that stuff. That stuff has to be kept 6 years. If you have a training log that you're using to prove that you complied with the training obligations, that needs to be kept for 6 years. But the actual documentation document retention policies is a state level.
Interesting enough, that's 6 years. It's the same for meaningful use, because you can go back and be audited 6 years for your annual.
Yeah. Okay. Yeah, I was not aware of that, but it's not surprising.
Does the HIPAA privacy rule permit hospitals and other healthcare facilities to inform visitors or callers about a patient's location in the facility and general condition?
Yeah, this is an interesting question. And there's a thing. So there's a general kind of outlier provision or whatever that a lot of people may not even are called incidental exposure, and within that they set up rules around certain types of information, like how it can be disclosed. So hospitals specifically are allowed to establish a directory with a very limited set of data that can include stuff like patient name, location in the facility, the condition of the patients expressed in very general terms, so like critical or stable, or what's there's some what is it on the TV shows?
Critical, stable condition.
Critical, stable.
Yeah.
So maybe, is it hot? Anyway, you get it. We're general terms, so you could say that the patient's out of surgery. That's general, but you can't say, oh, the patient, crashed during surgery and stuff like that. So, as long as it's very general, and then you can also, you can establish in this registration or registry religious affiliation, but you can't disclose that.
Right. You can't say they're Catholic and they called the priest or whatever. Yeah.
Exactly right. You can unless you are a member of the clergy, in which case you can identify that. And by the way, this registry does not allow for a phishing expedition. People have to ask for the information by name. So if they say, hey, John Smith, I understand was, I like John Smith. I'm using John Smith a lot. I need to be more creative.
John Doe?
No, let's say Randall Niemeyer.
Okay.
Randall Niemeyer was admitted here, it says, and you're able to disclose,
right.
like the condition and room, things like that. But you can't have somebody come and say, I think there was somebody in an accident here that, was here, and what room are they in, and what's their name? You can't disclose that information.
Right. What are your recommendations for getting rid of old computers?
Oh, good question. Yeah, I mean,
getting rid of. I got rid of all my Windows XPs.
machines. Yes, okay. You got all these Windows XP machines because you've dutifully, upgraded. So you have to have a policy governing disposal.
Yeah.
You have to have policy governing disposal. You need to properly dispose of that equipment. And so I recommend, just so you can save space, take out the drives, very easy to do, or have your IT, provider do it, and then store those drives in a safe, secure location until you can properly dispose of the data consistent with your policies. And I'm actually I'm a fan of using business associates, or offloading this responsibility to a business associate.
Oh yeah,
they need to be a business associate.
Plenty of companies out there that do that. Yeah.
Yeah, Shred-it, Iron Mountain. I mean, they all have services around this, so they need to have a business associates agreement in place because remember they're taking control of PHI, and then I really want them to use what's called a chain of custody. So you have this box that has 9 hard drives in it, and those are logged onto a sheet of paper, and they take you in this chain of custody, you're handing it over to them, and they're signing that they are now taking control of those. And then I would like that business associate to then provide what's called a certificate of destruction once the drives are destroyed.
Okay. Yeah.
And that should all be in your policy.
All documented, right? And speaking of policy and all that, what is the difference between risk analysis and risk management in the rules?
Okay, yeah. I don't get I'm not one I hear a lot, but I'm happy to answer because it's, I think, important. So risk analysis, as I've said multiple times in this podcast and in others, requires you to identify the risks and vulnerabilities to the confidentiality, integrity, and availability of electronic protected health information. So that's a process. It's a method. I liken a risk analysis to be like getting your home inspected. Guy comes in, most people will be an outside firm, and they're going to walk through, and they are trained to look and find that wire, it's bare wires in the ceiling of your or in the, between the joists in your attic that you've just gotten used to ignoring because it's been that way for years. So that's what you do with the risk analysis. Somebody, you basically, somebody identifies that and then documents it. The management plan is what you do to manage, it's your plan to manage the risks identified during your risk analysis. And risks that might be, like you have an incident a month later, you should, in that incident report, you should document like kind of those risks, and then you can add that to the risk management plan. And so I consider the security risk analysis to be more like a snapshot, and the risk management plan to be your plan to manage those risks. And it's more of a living document where you'll add to it. And I will say that the risk management plan is important too, because there may be some things that you want to do, but you can't do them today.
Sure.
So good intentions don't buy anything with auditors unless they're documented as good intent. Like, we are going to implement this control in our next budget year, and that's the kind of thing that you would put into your security management plan. And there might be, one of the things that we provide one of our three main deliverables with our risk analysis is the risk analysis report, obviously. We also include the risk management plan that we're talking about, and then we include policies and procedures. And you know, I tell my clients, I said, you know, we might have something we recommend and we rank it as something that's recommended or maybe just beneficial. And you know, you could say, no, we opted not to do this and here's why. You know, now we don't recommend people do that if it's a critical finding, but you know, there are others where it's your way of making decisions and documenting those decisions. And then the other thing too is there is another standard called the evaluation standard that's kind of like unto it, and that basically is a standard that says you have a positive responsibility to evaluate the risks or the security implications of your decisions, like to move to a new system or to move into a new building or whatever, and that needs to be documented. And the risk analysis is probably the most important tool in your tool chest to evaluate risks.
Right. So I'm going last question.
How's our time
here? We got 3 minutes, but I want to end sort of with like a bigger question.
Okay.
What is the biggest misunderstanding that people have about HIPAA compliance?
I kind of touched on, I mean, this is kind of a narrow answer to a kind of broad, I think a sort of broad question. But I think the biggest misunderstanding, and I say this because everybody is surprised when I tell them this. I've told this to attorneys who didn't believe me until I showed it to them. And that is who has to comply. It seems like basics, in that sense it's broad. Who has to comply with the HIPAA rules? And the answer, as we've already covered, is covered entities. But the thing that people, I think, is most surprising people is that who is a covered entity, and that there's this big and growing class of, for example, physicians that are not covered entities because they don't take insurance. So to back up, a covered entity is an organization or entity that engages in covered transactions, which is a predefined set of electronic transactions, and by engaging in these related to claims, to verification of coverage, to EOBs, I mean, all these things, those all make you a covered entity. But if you were a physician that only takes cash, which is a growing movement, my physician,
plastic surgeon, concierge,
if you're a plastic surgeon that doesn't bill Medicare, you only do cash customers or whatever, boutique or concierge, primary care doctors like my doctor just made that switch. They're not covered entities, and they technically don't have to abide by the HIPAA rules, and they cannot be prosecuted for civil liability, or they can't be sued for civil liability under HIPAA. I think that would even apply to criminal. There might be other, like obviously if a doctor were to do identity theft, then there are other statutes that could be invoked to deal with that, like the computer fraud and security, let's see, whatever. There are other things, but HIPAA would be off the table because they're not covered entities. People are totally shocked when when they find that out. They assume that if you're dealing
with the stars, like for example, he could.
Yeah, a boutique physician that only takes credit cards or cash, they're not a covered entity. So that's the one that surprises everybody the most.
Wow. All right.
So.
Well, Steve, another HIPAA chat has come and gone, and obviously we'll be back the third week of May. We're usually on board every the third Friday of the month.
Yeah, we're hoping to have an exciting guest.
Yes, we'll tease the audience with that. And
exciting guest.
Hope everybody
George Clooney and Sandra Bullock are definitely going to be in the house for sure.
In the house.
In the house. So,
I hope you all have a great weekend, and to our next HIPAA chat.
Okay, I'm looking forward to it.
Bye.
Bye, everybody.